Ideally 6 weeks.
6 weeks, 6 weeks, 6 weeks, maybe 3 times in a gap of 3 months, then he comes back again and we review. And we have already prepared the patient. We're talking about 1 to 2 years of this form of therapy.
So that wouldn't be every 6 weeks for 1 to 2 years, okay? It would be maybe, say, 3 treatments and give him a bit of a break and reassess him clinically and see what things are like for 3 months, bring him back for some more and do the same again. And you have to build in some flexibility as well.
Even between, you kept asking us to check the glucose levels. Is it important that we do that for everyone?
No, the 2 groups of patients where we would do glucose levels, if we were concerned, is if we were giving a large dose of doxycycline to a baby for a lymphatic malformation, and there is an extremely rare group of arteriovenous malformations in an overgrowth syndrome due to a PTEN gene mutation, like Banyan-Riley-Ruvalcaba syndrome or Cowden's disease, and actually they are at risk of hypoglycemia during arterial embolization, so we do put
the dose of doxycycline that
yes. So the dose of doxycycline, there's not much science, I'm sorry again, and so the maximum dose for a baby would be 300 milligrams. That's what we go on, and usually in the US and Canada that's about the approximate dose. And for a 12-year-old and above, 1200 milligrams. You may not need that much, actually, depending on the size of the lymphatic malformation. So in Canada, the preparation comes as a 100 milligram powder in a vial. We add 10 cc's of saline if you want to it, or you can add half iodinated contrast, 5 cc's of iodinated contrast and 5 cc's of saline if you want to. So you have 10 milligram of doxycycline, and then what you do is you puncture the cyst and you aspirate the cyst and replace half that volume with the doxycycline solution. Sometimes they all intercommunicate and you can keep injecting, and interestingly I've done one child with a extensive microcystic disease and not the child with the leg, and I injected one cyst and I could see it enlarging, and I thought, well, it's going to take not a cc. So I injected it, and I could see on ultrasound as I was injecting it the cyst increasing, and then it just suddenly decompressed, and I could see this bubble shoot in directions. So I injected some more, and more, and more, and more, and more, and I injected 50 cc's. So his lymphatic malformation was in his entire chest wall, and through actually 2 injections, we put in about 30 or 40. One patient, he actually about 35 cc's of doxycycline solution, so 350 milligrams.
Shall we go to the next case?
Well, ketorolac. Yeah. They actually get, for most of our patients who are 12 years and above, get a standard dose of 15 milligrams. I think the dose, if I'm correct, is 1 milligram per kilogram up to 15 milligrams, and they get 1 dose. You shouldn't give a dose more frequently than every 6 hours.
The second is of another child.
We now move on to our next case for the evening. This 18-year-old female presented with a large swelling over the left side of her face and neck, which was present since birth. Clinically, the mass was soft, compressible, with no evidence of thrill or bruit present. Ultrasound revealed multiple dilated venous with no evidence of arterial flow on color Doppler. MR showed multiple soft tissue intensity mass lesions over the parapharyngeal, sublingual, superficial and deep parotid spaces and in the cervical region. Which showed enhancement with contrast. A diagnosis of venous malformation.
Can we just actually point out one really important thing in this girl on her MRI, which clinically actually you used an endoscope or a bronchoscope you wouldn't know about, and she actually has 2 laryngeal areas affected by the venous malformation. And what's important for anesthesia is to know about these, because when they intubate the child actually for the procedure they can get bleeding from these. And the other thing is, when you're treating the malformation, some of your sclerosing may perfuse and diffuse into these locations, and as well as getting skin blistering, you can get blistering along the surface of these, causing bleeding. And they will swell like the venous malformation swell, and when you actually sclerose lesions, they evolve the swelling over a few hours. So what you see clinically with the patient when you finish the procedure is going to worsen over the few hours after the procedure has finished. So these could potentially increase in size. So this patient, we would never discharge this patient the same day as the procedure. And it's very important to be aware of this and also to let the anaesthetist know.
Is there any advantage of doing contrast in MRI when still images usually show the lesions quite well?
Well, actually, I find when I look at the MRI, I look at the T2 to start with, because it's nice and bright, it hits you straight away, and you can see it. And the nice thing about STIR and other T2 weighted imaging sequences is that actually if you see any phlebolysis in these lesions, these are virtually pathognomonic for venous malformations. You don't need MR angiography, MR venography, just some conventional T1, T2, maybe T2 fat sat and a T1 post-contrast, in whatever plane you like. Sorry?
What's the contrast and magnitude requirement? You've been asking for
I know, I've been asking for contrast.
Most of it in 5 centimeters.
But you don't always see, it depends on some of the malformations. If you have a small focal lesion and you're not sure if it's hypo-intense on T1 and hyper-intense on T2, could it be something else? And clinically, if it's difficult to make a decision, then it's very hard, especially if there are no phlebolysis in it. And maybe the enhancement may give you some clue. It's very traditional, the teaching, actually, and it's hard to move away from that. But I'll tell you from a practical standpoint, when I'm in clinic and I see a patient, and if they've come with an MRI from another centre, and I look at the T2, it's easy because I've seen the patient. And then when I look at the T2 and I say, oh yes, look at this hyperintense lesion on T2, and there are phlebolysis, well, definitely a venous malformation. But it's easy doing it like that. Often many of us are sat in a room with an MR in front of us and not the patient. And sometimes the history is not adequate as well. So it's important to get the message across to the people that request our MRIs to give us a good history as well, and for us to understand the reason for the good history.
Let's get on with the case. Now, before we start, this one, did you have any different approaches for this? You wired ultrasound for this, and
yes, we used ultrasound to guide our punctures in this malformation. Sometimes what you can do, actually, you can squeeze the malformation with your hand and increase the size of it and then puncture it. But really what you want to ensure is that you're inside the malformation. And because this was extensive, we decided to do treatments on consecutive days. We did the neck on day 1, and day 2 we did the left side of the face.
As you told in your discussion that we should have a goal for treatment in each case, and especially in a patient who has such extensive malformation.
Yes.
What was your goal?
Well, our goal for this because many head and neck venous malformations like this are painless, not pain. So often it's in the head and neck, it's more of a cosmesis issue and a cosmetic, to reduce some of the bulk and the swelling, try and diminish the coloration of it a bit as well. It's hard actually when...
see the needle coming in the ultrasound. You see there's a steroid
So this venous malformation on ultrasound is more sort of solid than sometimes those clear lakes that you get. So there is a slight variation in appearance on ultrasound, but don't let that put you off. When you put this Gelco in, remove the stellate and you will get some blood coming. But if you don't get blood, just withdraw the stellate, bring the Gelco out a little bit. If you attach a connecting tube and aspirate, you may not get venous return. If you take the syringe off, you sometimes see spontaneous venous return much better than with a syringe if you try and aspirate. So you can see it goes in easily, and this is where we started actually putting some adhesive tapes onto the tubing so that we weren't going to lose some of our access. There's a slightly more hyporeflective spaces in this compartment of the venous malformation. So what we've done is we've spread out the needle puncture sites throughout the malformation.
You can see the tapes and stuff, nothing moves,